हम्म।
मैम डॉक्टर अभी आलोक का फोन आया था आपने।
हाँ, बोलो।
और गलती से फोन आलोक को फोन कर दिया अभी।
तुम तो
Good
कर ही
evening to
सकते हो।
everyone present here with us today. This is Shreyan from IJCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Sunita Chandra. Ma'am is MBBS MD, Ops and Gynecology. Ma'am is also FICOG and also a laparoscopic surgeon. Ma'am is infertility specialist at Rajendra Nagar Hospital. Now, with the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is recurrent pregnancy loss and the use of NMP. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you. Thank you so much. Thank you, IJCP, for giving me this opportunity. I'm really happy. I'm really delightful to be here today evening on this platform to share my views, my presentation on recurrent pregnancy loss with a special emphasis on use of natural micronized progesterone in recurrent pregnancy loss. So a very good evening to all of you. I bring greetings from Lucknow. My alma mater is that I am a hardcore infertility specialist for last 30 years and I'm a Georgian. So that's all about me. So I'll start my presentation on recurrent pregnancy loss. Recurrent pregnancy loss, actually, it's a nightmare for all obstetricians who are treating these patients, and when they come again and again with the same problem that the pregnancy is not continuing, they are not giving a live birth, they have a pregnancy and it is failed every time. So I'll just start my presentation with this very standard, very new article published in June 23. This is a review article which actually reviewed 4,000 articles and 212 studies were included in this. According to this worldwide estimation, 2.5 crore cases occur annually. So you can see the burden of the recurrent pregnancy loss. That is why we keep talking about it. And still, I mean, there are no consensus for investigations, treatment. We are following ISHRI guidelines and our FOXY guidelines, but still we are in dilemma what to do, what not to do. This is a very, very important conclusion which was drawn in this review article. I just want to bring everybody's notice on this. Recurrent miscarriage is a traumatic life event that affects women's physical and psychological health and social well-being. I wanted to actually emphasize on this that this is not a medical problem. It's a social and psychological problem. So we have to look into it and we have to help these patients. Different international guidelines on RPL management are approved and implemented into clinical practice. My presentation is solely based on ISHRI guidelines, which are very, very latest 2022 guidelines. So I will be talking about definition, pathogenesis, etiology, investigation, some part of management, and use of natural micronized progesterone in RPL. So definitions also are many. Some say it is more than 3 pregnancy losses before 20 weeks, and they exclude ectopic, molar, and biochemical pregnancies. Less than 5% of women will experience 2 consecutive pregnancy losses, and that only 1% women will experience more than 3. Incidence of miscarriage definitely increases with age. Up to 35 years, it is 9 to 12%, while if it is more than 40 years, it is up to 50%. So these are the definitions, and they started the definition right from 1977 by WHO. So you can see that we are actually struggling with this RPL, and we are talking about it, trying to make guidelines since 1977 and till 2023. I mean, consensus is there, guidelines are there, but we are still in dilemma. So some organization says that it is 3 RPS. Some says it is 2, like ASRM and ISHRI. They say if 2 consecutive losses are there, we consider it as RPL. In some definitions, it is consecutive, and in some, it is non-consecutive also. I mean, it's not necessary that women will have 2 consecutive or 3 consecutive abortions. Then only we'll consider it as RPL. Suppose she had 1 good pregnancy and second RPL, second pregnancy loss, then third again good pregnancy, and fourth again pregnancy loss, then this will also be coming in RPL. So accordingly, there are multiple things, type of pregnancies, evidence of losses, histopathological has to be there, not has to be there. Gestational age 20 to 24 weeks are there. Again, some guidelines are defining the weight also. While ASRM and ISHRI, they have not specified the fetal weight. RPL can be primary or secondary. Primary means no live birth earlier, and secondary, एक कोई live birth हो चुकी है, and then patient is not able to have a live pregnancy. Epidemiology, almost 1% of fertile couples suffer from recurrent pregnancy loss, and 1 to 2% of pregnancies miscarry before 24 weeks. If a woman is having multiple high-risk pregnancies, then they are actually on high risk of recurrent pregnancy loss. And as described in NCBI guidelines, that the population which is high, where the incidence is higher, is non-educated and low socio-economic groups, but this does not hold true nowadays, because we see RPL in all class of patient, all group of populations, all socio-economic status. It is no longer a poor socio-economic status disease. And RPL, as I said in the beginning, has high impact on couples and even more frustration and impact on doctors. Because every time patients comes to you with a positive pregnancy test, and you are actually in a dilemma whether this pregnancy will continue to a live pregnancy or not, unless you really give her a live baby, you are also in extreme frustration and dilemma and distress. Many causes, many investigations, but few specific treatment till today. Let's look at the etiology. Etiology may be immunological, endocrine, anatomical, inherited thrombophilia, antiphospholipid syndrome, genetic, and lifestyle factors. So if we see, anatomic factor is around 10 to 15%, autoimmune is 20%, genetic is 2 to 5%, infections 0.5 to 5%, endocrine 70 to 20%. In this, hyperprolactinemia may be there, thyroid hypo or hyper, diabetes very, very important, PCOS again important, and the most important is luteal phase defect. But you can see 40 to 50% patients are with unexplained causes, which includes non-APS and thrombophilias also. If we talk about immunological factors, women with recurrent spontaneous miscarriage have a greater bias towards a Th1 type or pro-inflammatory cytokine profile as compared to women with healthy pregnancy. So what does it mean? Usually in healthy pregnancy, the women have a shift towards Th2. From Th1 to Th2. If Th2 is more, that means this pregnancy is going to be a healthy pregnancy. This we are studying since beginning, since we have started knowing about immunology. When there is a shift from Th1 to Th2, it is always better. It will for continuing the pregnancy, for giving a healthy pregnancy, healthy child. So it is seen that in women who have healthy pregnancy, they have more Th2. Women with healthy pregnancy have decreased Th1 cytokines and increased Th2 cytokines. तो यदि कोई भी ऐसा प्रोडक्ट है जो ये शिफ्ट Th1 से Th2 कर देता है, तो that means this is good for the pregnancy. It is in favor of pregnancy. If we talk about endocrine factors, it may be thyroid, polycystic, hyperprolactinemia, and corpus luteum insufficiency, that is luteal phase defect. Anatomical factors may be congenital, may be acquired. The pathogenesis is that because of uterine abnormalities, there is reduced intrauterine volume and poor vascular supply. Congenital may be anomalies of the uterus like didelphic, unicornuate, bicornuate, septate, and so on. And if we talk about acquired anomalies, then it may be polyp, fibroid, adhesions. Anatomic factors, if we see the different factors like septate being the most important cause, 65%, and bicornuate is 30%, and likewise, unicornuate is 50%. I mean, all of you will agree with me that we quite a lot see the patients of unicornuate and septate uterus. Fibroids, all of us know if the fibroid is very big, then it may cause abortion. Fibroid is compressing the endometrium, then it may cause abortions, and accordingly, you have to remove the fibroid, which is occupying the endometrial cavity. Same thing with polyps also. And adhesions, because of poor vascularity, they don't support the pregnancy. If we talk about inherited thrombophilia, then there are factors which increase the risk of venous thromboembolism. And these are factor 5 leading, prothrombin gene mutation, protein C and protein S deficiency, antithrombin 3 deficiency, and MTHFR mutation. What happens in this? In normal pregnancy, there is a normal size clot which breaks down after a few seconds to minutes. While in thrombophilia, the clot size is big and it does not break down. And that is the most important thing, that it does not allow the pregnancy to grow. In antiphospholipid syndrome, again, we can have, it is an autoimmune disorders, all of us know. And the antibodies which are associated with thrombosis are lupus, anti-cardiolipin antibodies, IgG, IgM, antiphospholipid antibodies, and beta-2 glycoprotein antibodies. This condition can affect various organs and systems. Not only pregnancy, but other systems and organs can also be affected. If we talk about genetic factors can be at 2 levels, embryo level or parental level. Usually the early pregnancy losses are because of chromosomal abnormalities. At embryo level, there may be embryonic aneuploidy, and at parental level, if we talk, there may be balanced structural chromosomal anomaly. Most common is balanced reciprocal and Robertsonian translocation, which causes unbalanced translocation in the fetus. If we talk about embryo, then anomaly may be in egg or sperm or both. Most common is monosomy or trisomy, and these are responsible for spoiled egg miscarriages. Then very important part nowadays, lifestyle factors, smoking, alcohol, drugs, heavy coffee consumptions, obesity, and stress. Everything is very, very important. Nicotine when we smoke, or hookah, alcohol, again, actually alters the quality of egg or sperm. And gone are the days when we used to talk about males for smoking and alcohol or drugs. Now, I mean, you have to take the same history from females also for smoking, alcohol, and drugs. And coffee, because in the office, they just keep on drinking coffee without even realizing that how much coffee they are consuming. Obesity, all of us know, is a very, very important factor of infertility, of miscarriages, of multiple complications in pregnancy. Stress, again, whether it is stress in the office or at personal level or in the family, is very important for miscarriages. So after talking about the etiology, we just go about investigation. Which investigations to be done, which investigations not to be done, which are very, very important, has to be done in all the cases, and which can be done in some cases. So history, as in other patients, is very, very important. History, medical history, family history, and examination from head to toe is again very, very important. I mean, if you see the face, you see facial hairs, acne, this patient may be polycystic ovarian disease. If you see fat in the neck or like blackness in the back of the neck, that is acanthosis, again PCOS may be there. Milk or discharge coming from the breast, it may be hyperprolactinemia. There may be some lump in the abdomen. Maybe she has fibroid. Maybe she has some ovarian. So examination from head to toe, pubic hair, a vaginal examination, cervix, one cervix, two cervix, whether it is a no cervix, whether the os is clearly visible, whether she has had some labial synechia or something, maybe there is problem of that. So you have to actually examine from head to toe, and then only you come to know that yes, the history and examination is a very, very important part in any kind of disease, whether it is pregnancy loss or any other thing. Then we go for screening, immunological screening, endocrinological screening, anatomical investigations, thrombophilia screening, antiphospholipid, and genetic factors. So history again is a important thing, and this can be used to tailor diagnostic investigations. And age is very, very important, and complete pregnancy history, including number of previous pregnancy losses, live birth, and their sequence. It is a very, very strong recommendation from history. Immunological screening, HLA, not to be done in all the patients, but where it is needed, it can be done. Otherwise, not every patient needs HLA testing. Today only I had a couple, and the male was suffering from reactive disorder, and when I went through the profile, and it was reactive arthritis, and it is an autoimmune disorder where he was HLA B27 positive. So this is very important, because this kind of patients, either just as she was not conceiving, she came to me with infertility. Even if she conceives, she will have recurrent miscarriages. So in these patients, HLA testing is required. Anti-HY antibodies, again, should not be done in all the patients. Actually also recommends that it is not to be done in all the patients, only in some patients where it is required. It should be done. Otherwise, measurement of anti-HY antibodies in women with RPL is not recommended in clinical practice. Cytokine testing, again, is not to be used. Cytokine polymorphism should not be tested in women with RPL. Antinuclear antibodies should be considered for explanatory purposes. And NK cell testing, again, is not recommended in all the patients. Endocrinological screening, TSH, T3, T4, TPO antibodies, prolactin, and blood sugar levels should be done in all the patients. Based on a high prevalence of subclinical hypothyroidism and thyroid autoimmunity in women with RPL and potential of treatment options, testing for thyroid function is strongly recommended. Abnormal TSH levels should be followed up by T4 testing in women with RPL. For diagnosing PCOS, there is no need to investigate insulin metabolism, because PCOS can be diagnosed only by examination and history. There is no test which can actually tell you that it is PCO. So history and examinations are very, very important, but insulin levels are not to be done in all the patients. Same thing goes with luteal phase insufficiency. It is not recommended. The test is not recommended in all the patients, like serum progesterone on day 5 of luteal phase, or endometrial biopsy just to look for luteal phase defect. So history again is important, the length of the cycle, but it is not important to diagnose it, to test the luteal phase insufficiency. Anatomical investigations are best diagnosed by ultrasound. So all women with RPS should have an assessment of uterine anatomy, strong evidence. The preferred technique to evaluate the uterus is 3D ultrasound, which has a high sensitivity and specificity and can distinguish between separate uterus and bicorporeal uterus. Sonography is more accurate than HSG. 3D ultrasound, where it is not available, then sonography can be done. If a Müllerian malformation is diagnosed, then obviously you have to look for kidneys and ureters. MRI is not recommended as first line of options. If 3D ultrasound is not available, then only it can be used. And all women with RPL should have 2D ultrasound to rule out adenomyosis. Antiphospholipid syndrome, very strong recommendation that after 2 pregnancy losses, lupus, anticoagulant, anticardiolipin antibodies, IgG, IgM should be tested. For women with RPL, screening for beta-2 glycoproteins can be considered after 2 pregnancy losses. So now, after the history, after investigations, we come to the management part of the RPL. So when we talk about antiphospholipid syndrome, This can be treated with aspirin and heparin. And it was seen that if we treat with combination, then pregnancy rate are higher rather than treating alone with aspirin. So the consensus is that we should give aspirin with low molecular weight heparin to have better chances of a live birth. This is 2021 article. This again says that aspirin and low molecular weight both should be given to increase live birth rate. Congenital malformations, again, if there is septum, you have to treat it. If there is bicornuate uterus, we just leave it as such. Unicornuate, we cannot do much. We can just do something like cavity enhancement with hysteroscopy. Cervical answer class, all of us know, should be given in some class of patients where it is needed. It is not done in all the patients. But actually, if patient is having history of second trimester pregnancy loss, then this or the multifetal pregnancy is there or cervical length is shortening continuously, then I think this is most important. But for all the patient, it should not be given because of the risk of stimulating uterine contractions. And so it should be considered only in women who are likely to benefit with it. Now we come to the genetic factor. Genetic counseling is very, very important. And in this, we can actually take help of assisted reproductive techniques like IVF, ICSI, or PGD. And if the male is at fault, we can go for donor sperm. If the female is at fault, we can go for donor eggs. If both of them wants their own gametes, then PGD, pre-implantation genetic diagnosis, can be offered to all these patients. For lifestyle management and some factors in male like smoking, you just can't ask the smoking cessation, but you can ask them to reduce cigarettes. Obesity, yes, weight management is very, very necessary. If they are taking some medicines like corticosteroids or other medicines which can harm sperms, then these male partners actually can be told that you have to look into it, and these are risky. So you can reduce the doses, or you can just talk to your doctor to change your medicines. If there is varicocele has to be repaired. Sperm selection can be done as in ICSI, we do sperm selection, and nutrition and antioxidants are very, very important, like astaxanthin, like lycopene. These supplementations can be done. Then we can go for some non-conventional treatments like Chinese herbal treatment, acupuncture, and antioxidant, as I said, which can be given to all the patients to decrease reactive oxygen species. Now we come to the last part of it, that is clinical evidence in favor of natural micronized progesterone in patients of RPL. So what does progesterone do? Hormonal actions are maintains uterine quiescence, inhibits myometrial contractions, and the most important, endometrium is converted into secretory phase, and this increases vascularity of endometrial lining, and it stimulates growth of uterus and stabilizes endometrium. If we see the non-hormonal action, then it is uterine relaxant. Number 2, it acts as immunomodulatory. From TH1 to TH2 shift, and that is what is needed. As I said in the beginning, if anything which causes the shift from TH1 to TH2, it is the most important thing for us. It modulates chemokines transcription factor and inhibits tissue rejection and protect conceptors. Progesterone prepares the endometrium for blastocyst implantation and controls endometrial development. It is indispensable for establishment and maintenance of pregnancy. All of us will agree with this. Since our medical days, when we started studying, we know that first phase of menstrual cycle is estrogen dependent, and second phase of menstrual cycle is progesterone dependent. And if we actually need a healthy pregnancy, then we need proper progesterone secretion from corpus luteum, and then only pregnancy can continue further. So role of progesterone, endometrial changes fail to develop if progesterone production is lower than normal. Lower than normal plasma progesterone concentrations, then retarded endometrial development in peri-implantation period, and it causes pregnancy loss. So progesterone, now we have decided that we have to give progesterone, but then what? Because there are multiple preparations in the market. If we talk about natural micronized progesterone, they are also in the form of vaginal tablets, vaginal passages. effervescent tablets, oral SR preparations, rectal use of pessaries, injections, intramuscular and subcutaneous, both are available. So you have oral, you have vaginal, you have rectal, and you have injections, intramuscular and subcutaneous. Have to decide according to patient, according to patient's preference, according to your preference, according to patient's comfort. So I'll just talk about two trials, PRISM trial and PROMISE trial, and then we'll come to SMILE study. The PRISM trial, the two groups of patients, it was a very big trial, and where the history was there for vaginal bleeding and intrauterine gestational sac was there, 4038 women. That means it is a big study where it was seen that the patients who took micronized progesterone, live birth rates were more in a female who had history of 3 or more previous miscarriages. PROMISE trial, again, this studied 836 women from 45 hospitals in United Kingdom and the Netherlands and found 3% greater live birth rate with progesterone, but with substantial statistical uncertainty. Key finding in the PROMISE and PRISM trial was vaginal micronized progesterone 400 milligram BD was associated with increasing live birth rate according to the number of previous miscarriages. If the number of previous miscarriages were more and we gave progesterone, then the live birth rate was more. But then came this SMILE study, which was published in Journal of Maternal Fetal Neonatal Medicine in 2018. In 2015, PROMISE trial was there, which concluded that daily vaginal progesterone in first trimester do not increase ongoing pregnancy, but increases live birth rates. While this SMILE study, what happened in this, that the treatment started in the luteal phase prior to implantation and confirmation of pregnancy. Therapy continued till 28 weeks of gestation, and the best part was that they measured cytokine levels in first, second, and third trimester, and it was found that this cytokines levels were more in these patients where progesterone was given. In this trial, measured the cytokines levels through first, second, and third trimester and found greater changes in vaginal progesterone group than placebo group. This reflected the strong immunomodulatory actions of progesterone that may be behind the lower miscarriages and higher live birth rate. The doses were 400 milligram vaginal progesterone twice a day from luteal phase and continued after positive pregnancy test up to 28 weeks of gestation. And that is how they had less of premature deliveries, more of term live births. So the evidence was in favor of strong immunomodulatory action of progesterone, significant progressive decrease in T1 and increase in TH2 cytokines were seen throughout first, second, and third trimester, which was very, very important finding. And this actually gave the importance to this SMILE study that progesterone treatment should be initiated after documentation of ovulation. They continued till 28 weeks of gestation, and this could improve the live birth rate in women with recurrent miscarriages. And the best part was that because they measured cytokines level through first, second, and third trimester, so they could prove that progesterone has some immunomodulatory effect. The shift is there from TH1 to TH2. So this was the first study which uses vaginal progesterone in the periconceptional period in unexplained recurrent miscarriages group. And I think all of us will agree with this. When a control cycle is there where we do give something for ovulation, then we monitor ovulation, and then we ask for time intercourse, and then immediately after ovulation we start progesterone, these patients definitely do better rather than when we confirm pregnancy and then we start progesterone. So this was again with history of miscarriage 2020 study, where the woman, if presents with bleeding in early pregnancy, they may benefit from the use of vaginal micronized progesterone 400 milligram twice daily. Now let's see the guidelines. What are the guidelines? What are the recommendations from different guidelines? So this is French clinical practice guidelines among women with a threatened late miscarriage and isolated undilated shortened cervix and no uterine contractions. Daily treatment with vaginal progesterone up to 34 weeks of gestation is recommended. ASHRAE guidelines 2017, and then the amendment was there in 2022, updated guidelines. Vaginal progesterone may improve live birth rate in women with 3 or more pregnancy losses and vaginal blood loss in a subsequent pregnancy. Cochrane review for women with unexplained recurrent miscarriages, supplementation with therapy may reduce the rate of miscarriage in subsequent pregnancies. NICE recommendations: progesterone should be offered to women who experience bleeding in early pregnancy and have previously had a miscarriage. Proxy position statement: progesterone support in recurrent pregnancy loss and threatened miscarriage. The doses are micronized progesterone 400 milligram twice a day vaginally up to 28 weeks of pregnancy. So this article, I started with my presentation with this article only, 2023, where they say that prevention of pregnancy loss. For prevention of pregnancy loss, we should combine progesterone treatment with psychological support. Psychological support is very, very important with pharmacological support. Now, if we see the books, textbooks, they are all full with the chapters where this importance of progesterone is there to reduce preterm birth, for luteal phase support. Vaginal progesterone has potential beneficial effect in postponing preterm labor. In asymptomatic short cervix patients, vaginal progesterone is important till 34 weeks. Vaginal progesterone reduces preterm birth. So many. All the books have all the books have chapters which explains that the importance of progesterone is there for recurrent pregnancy loss patients, for preterm birth patients, and to have better chances of live births. So what are the messages we want to give? Counsel the couple, most important. Recurrent pregnancy loss is an important reproductive health issue. Various etiologies have been identified over the years, and successful therapeutic strategies have been implemented. A full workup can be initiated following 2 consecutive losses to identify treatable causes that include uterine abnormalities, antiphospholipid syndrome, endocrine disease like diabetes, thyroid, prolactin levels, and balance translocations. Lifestyle modifications should also be implemented to improve reproductive prognosis. However, almost half of the cases remain unexplained, for which various treatments are continuously being developed. Regardless of the cause, a thorough follow-up with an important psychological support can help most couples achieve a successful live birth. Treatment has to be individualized. The same treatment cannot be given to all the patients. Use of progesterone is recommended in the treatment of patients with threatened abortion and recurrent pregnancy loss. 2019 Cochrane review suggested progesterone supplementation may reduce the rate of pregnancy loss in further pregnancies. Again, 2020 meta-analysis concluded that progesterone versus placebo or no treatment, progesterone in the progesterone group increased live birth rate was there. Use of vaginal micronized progesterone and spontaneously achieve singleton pregnancies with threatened miscarriage before 20 weeks of pregnancy may reduce the risk of preeclampsia in later gestational weeks. Studies have shown that vaginal progesterone led to improvement in fetal outcomes. Guidelines recommend progesterone in recurrent pregnancy loss and threatened abortions. The management should be based on the diagnostic findings and based on the existing guidelines and recommendations. More evidence is required to clarify whether treatments with corticosteroids, IVIG, and vitamin D are justified for patients with RPL due to these factors or due to some anomalies. Once we have multiple failures, we start giving these things like corticosteroids, like IVIG, but we have to justify before giving all these things. Thank you for your patience listening. a very happy new year to all of you.
Thank you so much, ma'am, for your wonderful presentation. So, ma'am, we do have some questions from our audience if you'd like to take that up.
Yes.
So, ma'am, the first question is, how can preconception care be optimized for patient with a history of recurrent pregnancy loss?
Yes. Very important. Very nice question. Preconception care, one thing is folic acid supplementation, which we all are giving, vitamin D supplementation if it is deficient. And nowadays, even vitamin B12 supplementation if it is deficient. Otherwise, there is no need to give. Then comes a very important part is psychological support, which is very, very important. Psychological support because these patients are broken. They are socially, but they found themselves as if they have some social stigma. So psychological support is very, very important. Just talk to them. Just listen to them. Be all ears to them. Yes, talk about it. You will be having a healthy pregnancy. And then we can have a some tests which are related to recurrent pregnancy loss. And we may find some cause and we may treat it and then ask them to get pregnant. Sometimes we do not find any cause, but still we can give them some kind of treatment to prevent pregnancy loss, like progesterone support, which is very, very important. Then we have something like aspirin, which can be started earlier. And once the pregnancy is positive, low molecular weight heparin is started. So these all things can be done in periconceptional period, where we have to take proper history, some investigations, and then decide the treatment part. And overall, psychological support, which is very, very important.
Thank you, ma'am. The next question is, what challenges may arise in interpreting genetic test result in the context of recurrent pregnancy loss?
Very right. So actually, if we find some problem like translocations or Robertsonian translocations in male or female, or we have something like other factors in females or male, then we have to counsel them that, see, you are having this and you may go for donor egg or donor sperms likewise wherever there is a problem. Or we can just offer them peri-implantation genetic diagnosis, like we go for IVF ICSI, we make the embryos, and then we see the euploid embryo test for pre-implantation genetic testing for aneuploidy, and the euploid embryos can be transferred in the female, expecting that once we are transferring euploid embryos, we'll get a healthy pregnancy.
Thank you so much, ma'am. The next question is, how might emerging technologies or research finding impact clinical practice in the near future?
I could not get your question. What is the question? Please repeat it again.
Sure, ma'am. So the question is, how might emerging technologies or research findings impact clinical practice in the near future?
So see, medicine is always emerging. Medicine, you have to keep yourself updated. Okay. Nowadays, we have to practice evidence-based, one thing. I mean, your experience is important, but evidence-based medicine is very, very important. And it's always having something new. When we were studying 30 years back, we never had even ultrasound in our hospital. In hospital in Lucknow only, we just had one ultrasound. You will not believe, my senior delivered 2-term anencephalic baby because we never had any ultrasound in Lucknow. So this was 30 years back. Then ultrasound came. Then ultrasound piche ho gaya, 2D, no, now 3D, 4D. And then came this MRI, CT scans, even functional things. I mean, investigations, interventions are continuously evolving. Same thing is with the treatment. Once you know that this is there, now actually, initially we never had so many diagnostic modalities. Now we have all that. Talk about even if we talk about genetic abnormalities, we could never diagnose this, but now we can diagnose whether this is there is a problem in this. Like if we are seeing some problem in the family, osteogenesis imperfect, I mean, I can see the babies that it is there, but there was nothing to diagnose it and to say, yes, you are at fault and please look into it, or we can go for PGD and all, because we never had all this to offer them. So, I mean, technology is evolving continuously, and we have to accept it. Initially, it was only IVF, then it came ICSI, then ICSI and PGD, PGTA. Then there are so many things which were there to improve recurrent implantation failure, like you were doing ERA to just know the window of the implantation. So this is one thing I'm talking. Same things. Uh, we were not actually doing the test of thyroid in all the patients who are coming to us. Uh, Maybe just basic test. But then thyroid and prolactin were two very, very important parts. Then came AMH, then came other things which were very important to see in those infertile patients. So, I mean, because it's a ever evolving process, we have to keep with it. We cannot just say that I'm doing this and I'll keep on doing this. No, we have to go. Medicine um, is very challenging. You have to accept it.
Thank you, ma'am. The last question from our audience is, how frequently should testing be conducted in case of RPL?
How frequently? Okay, so no, I actually the testing is in RPL. What we do is basic test is CBC. You are doing in all the patients. Then you are seeing blood sugar, especially DTT. Then thyroid, prolactin, AMH is not important in recurrent pregnancy losses. And then if I talk about antiphospholipid, like antiphospholipid antibodies, anticardiolipin antibodies, this should be done not immediately after abortion, minimum after 6 weeks after abortion, and then they can be repeated after 6 weeks again. 3D ultrasound or 2D ultrasound is must on the first visit only to rule out all kinds of uterine anomalies, like maybe congenital, like septum, or maybe it's like uniconjugate uterus, biconjugate uterus diadelphus, or maybe some fibroid is sitting right in the endometrial cavity, some polyp is there. So basic is like TVS, one transvaginal sonography, whether it is 2D or 3D, is the most important thing. And you can do it again and again. That's not a problem. For other tests, thyroid, if you've done and it is normal, this should not be repeated before 3 months. But if it is antiphospholipid, then it has to be repeated after 6 weeks of abortion. A gap of 6 weeks is necessary. Otherwise, you'll not get the clear reports. If we talk about anti-TPO antibodies, बहुत ज़्यादा फर्क नहीं पड़ता है whether you get it done once or twice, because there is no treatment for it. It's just that you keep the thyroid levels at par. Otherwise, even 1,000 anti-TPO antibodies may be bad, or even 5,000 may be bad. Usually, it has been seen that no medicine reduces anti-TPO antibodies levels, but these are very, very important in recurrent pregnancy losses. If we talk about some immunological tests like IL-10, IL-6, TNF-alpha, all these tests can be done, but not in all the patients, because these cannot be done at every place. And then, I mean, you don't do much for that. Okay, so there's no need to repeat it again and again. Prolactin levels, yes, if one level is normal, but you feel that this patient may be hyperprolactinemia, then do it in the morning. Early morning samples are very, very important. Same thing goes with thyroid testing also. Early morning fasting samples are important. Sometimes you get a report of thyroid like 17, 20, 40. Then you don't start treatment immediately. You can get it done after a week or so. Fasting level, TSH, T3, T4. And then you know whether this patient is hypo or hyper, what is it all about. So it's not a rule that you have to do it repeatedly. But if I talk about thyroid and the patient is euthyroid, then you can just repeat it after 3 months. In pregnancy, again, we repeat it sometimes after 6 weeks, sometimes after 8 weeks. But usually, repeat test after 3 months is needed. Not very regularly, every month you don't need, but in pregnancy, nowadays, it is recommended that you should do it thyroid levels every 1.5 months so that you catch it earlier and you treat it earlier.
Thank you so much, ma'am, for answering all our questions. Before concluding today's session, any last remark from you?
From me.
Yes, ma'am.
Okay. So, RPL, as all clinicians know, as all of us are aware of it, that it's a distressing problem for patients and for doctors. So please be patient with yourself also. If you get a patient, like I had a patient, she had multiple abortions. I mean, just at 6 to 7 weeks, she will have some bleeding. And when I do ultrasound, and it was like only empty gestational sac. And it was very frustrating. Third onwards, I started giving her low molecular weight heparin with aspirin, but I gave her 40. I never gave her 60 because her weight is just 54, 55. So I thought this will be a optimal dose for her. Then this time when she became pregnant, I got everything done. Then I started on 150 ecoaspirin and 60 microgram low molecular weight heparin. And now she's 11 weeks. She's continuing well. So you have to be patient and you have to think and think and think. In a RPL patients, you have to sit with it, see all the reports, see her files. I mean, maybe you are missing something. These patients need your time in your busy OPD. So you can call them when you have time, when you can give them 40 minutes, 50 minutes. So my take home is that in RPL patient, you have to be patient rather than the patient. Patient to bichara patients rakh hi raha hai. But unless the doctor are patients, doctor do not have patience, do not have time, they cannot give proper treatment to these patients. And overall psychological support is very, very important to all these patients, all these couples, actually, I will say. Not only females, all these couples, they need your tender loving care.
Thank you so much, ma'am, for this lovely session. And thanks for joining with us with your